Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the Wrap Venous Cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the Wrap are available. For venous femoral access, the LivaNova Wrap cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of Wrap improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
He's pretty serious too. And welcome to the program, everyone. Welcome to our first Journal Club, PerfWeb 51, Journal Club 13, first program of 2021.
Yep.
Okay, we've got a really good program, I think, today. We're going to be doing the Tammy Sparacino Journal Club, which you all have come to really enjoy, I think. I do. And it seems to be really growing in popularity, so I'm proud of that. I know you should be I'm proud of you.
Thanks.
It's been fantastic. We're going to be introducing a new concept that I think you all are going to be very excited about. You can probably see it on the PerfWeb website, the John Ingram Knowledge Nuggets. That's good. It sounds, you know, John, I'll tell you, John, if you're listening, the board called me and said, well, what's a knowledge nugget? And I was like, look, you know, I mean, let me give you the guy's number, okay? It's a knowledge nugget. It's kind of like a nugget of knowledge. And they were like, well, that just sounds like you said the same thing, only backwards. And I said, I did. But we got it through, and I think it's really going to be neat to have that. I just love the concept.
It's a better name than mine.
Tammy Sparacino Journal Club has a terrific ring to it.
That's not T-shirt quality. Knowledge Nugget, that's a T-shirt.
Okay, all right. Well, you know what? Well, 2022 is just around the corner.
Okay.
And we could do something maybe COVID associated for your program.
Okay.
Yeah, COVID insanity, because it has been. Okay, I know I need to do this, but before I do it, because there's so many things I've got to talk about before we get to the program, the actual meat of the matter, so to speak. I was actually going to ask Tammy a question. And Tammy told me that if you ask me that question when we're live on the air, I'm going to throw my microphone down and walk off the set. So if anyone wants to know what that was, keep watching the program, because one day I'm going to reveal it. So our sponsors, Levanova, Siemens, and HET, Houston Extracorporeal Technologies, please. And there's going to be something about HET actually at the end of the program. You may want to stay tuned and watch about that. But those are our sponsors. Please check them out. It would be greatly appreciated by me. Social media, Facebook, Twitter, YouTube, LinkedIn. Make sure you like us, follow us, share us, give us the thumbs up. Subscribe. That's very important. Subscribe is very important. We are absolutely, without a doubt, #1 on YouTube for subscribers for any perfusion education resource. And we continue to grow every day. And these are solid subscribers, not ghost subscribers. And we're beating everybody. So I'm very proud of that. So thank you all for that. Our websites and contact information, please, you can get a hold of us at perfweb.us. That is where we have the schedule for all of the programs for the rest of the year. And then also perfusioneducation.com, which is where our library is and where you can join. Membership is free, and you can, of course, look at our entire library as many times as you'd like. But you can also, if you need CEU certificates for your board certification, you are able to go on that site, become a member, purchase the products for your certification. We have an unlimited package, which is good for 3 years. $450 for 3 years. I mean, that's really a heck of a bargain if you think about it. You can get all of your education throughout the year. You'd always make sure you have plenty. And, we don't know when meetings are going to come back. So I seriously, I strongly would hope that you would take, serious consideration in viewing these sites and joining our continually expanding subscription list and group of people, because we want to build a real community here. Our call-in number, nobody ever uses it, but we're still keeping it up and on. Would love for you to call it one day. If anybody calls in, I will personally tell you what I was going to tell Tammy. 832-239-5358. And David, if I give you the signal, make sure you put the camera on Tammy, because I want it to live in perpetuity, her throwing her mic and storming off the set, okay? I want to talk very quickly about our new Mediweb app. If you haven't already got it, we've sold a lot of them, but we still need about 900,000 more to go so that I can please retire. That's what I need. I need 1 million purchases to retire. But the critical care application for perfusionists has everything in it. It's got perfusion quick calcs, gives you your flows, your heparin dose, it gives you, it'll calculate your SVR for you. It'll calculate your predicted hematocrit for you. It gives you great information, including, allowable blood loss, for example, during a major surgery. What is actually going to happen here? And there's also a medication app. So if you are, you have nurses that are friends of yours, or maybe ECMO specialists that are working in critical care units, this app would be very applicable to them. And especially for the nurses, the medication portion of the app is quite comprehensive, and I think they would really enjoy that. So check our app out, and please buy it. Give it as a Christmas gift or whatever, birthday gift throughout the year to your children. It's never too early to start using the Mediweb Perfusion Calculation app, ever. Mm-hmm. So that's a good one. Yeah. You can even get one for your pet. So I want to get started today, but I got to tell everybody, I'm punch drunk. Tammy and I, and everyone on our team anyway, we have, they say it gets darkest before the dawn, right? Or the dawn. How does that go? The darkest before.
It's darkest before the dawn.
Yes, darkest before the dawn. That is how the phrase goes. And we certainly are in a very dark time, and we're hoping that we have seen a peak. But our number of patients that we have, the number of COVID patients in particular, the number of critically ill ECMO patients has exploded.
Again?
Again, yeah, well, this time even worse than the last time.
Yes.
And we thought the first explosion was bad. I just hope the heck there's not one worse somewhere down the road because our system is really taxed. Mm-hmm. And this has been very difficult to manage. But we are managing it, but we hope, of course, our colleagues out there are staying safe, and that you're able to manage your own practices, but you and your families are staying safe, because that sort of circles me around to the actual topic of today's presentation, today's review of an article that was written and then discussing it. And for a long time, I really was always amazed at how what I perceived as infrequently healthcare workers were coming down with COVID. And I really thought, do we have some kind of inherent immunity because we're always around stuff? I really wasn't certain. But then you saw this article and brought it to my attention. And, of course, it's titled Prevalence of SARS-CoV-2 Infection in Previously Undiagnosed Healthcare Workers. And this is from New Jersey at the onset of the U.S. COVID-19 pandemic. And apparently we are disproportionately affected by it, according to this data and many other articles that have been written now. So I found that very fascinating, because I actually thought it was the exact opposite of that. So I'm very surprised. So with that said, I'm going to turn this program over to Tammy Sparacino for Tammy Sparacino's Journal Club numero uno for 2021. Tammy, and thank you for doing this.
Yeah.
It's been a great program. It really has.
Well, good. I've enjoyed doing it. It's lots of fun. Okay, thanks everyone for joining us. I know you're probably busy like we are, so we appreciate you taking the time. This article, as Joe introduced, it was actually written in March 20, the data was collected March 24th through April 7th of 2020, so it was right at the onset. And so I thought that in particular made this article interesting because very early on, you know, some people at Rutgers University, Barrett and Horton, thought that this would be useful information, and I think it is. And there's been other articles written since then, but this one in particular I thought was great because it's one of the first ones that I could find that were really looking at healthcare workers and whether or not we were getting infected and just going undiagnosed. Mm-hmm. Okay. So this was published in November 16th, 2020 in BMC Infectious Diseases. The abstract, I'll just briefly go over a few of the things. Some of the other things we'll get into as we go. But the background, healthcare workers are presumed to be at an increased risk for severe acute respiratory syndrome from coronavirus 2 infection due to the occupational exposure to infected patients. However, there has been very little epidemiological research to assess these risks. Okay, so why was it published? Well, the main significance, of course, is we want to find out if healthcare workers are, being undiagnosed and they are infected. But they brought out actually a couple points that I think maybe most people aren't aware of. And it all has to do with why this is even more significant than just knowing, are we getting sick? I'll just read to you a little briefly in their background. So it says, our understanding of exposure among U.S. healthcare workers is hindered by several key issues. One, there is an underreporting of infection in the critical population. CDC's data indicates that 84% of all reported COVID-19 cases had zero information as to whether or not the people were healthcare workers. So 84% have no idea if they worked in healthcare or not. Second, among healthcare workers and non-healthcare workers, access to testing has been very inconsistent. So certain areas, might have easy access, and all the healthcare workers are, getting tested, weekly, daily, whatever it may be. And other places didn't have testing available at all. In addition, non-healthcare workers, many of them are not getting tested at all. So that's going to skew the numbers as well. They were just staying home, locking down, and especially the asymptomatics, we're not going to have good numbers on those. Let's see. Then importantly, here's what was most important for the significance, and I think we've come to understand this a lot more than initially that these authors would have since we've lived through almost a year of this pandemic. It's that the asymptomatic or mildly asymptomatic individuals will still transmit the virus and may actually represent one of the largest ways that we are transmitting the virus to the population. Mm-hmm. Okay?
That makes sense.
Yeah, of course it makes sense. And if we're going to work and we're asymptomatic and we're needed at work, we could be spreading it everywhere, mm-hmm. and then causing our own little mini pandemic with just the workers there, mm-hmm. right?
Which then filters out beyond there.
Right.
I mean, it's a weird thing. It's almost like a toxic gas that has no smell or anything, but it gets in you and you don't realize it until after it's had an effect.
Right, and I don't know why this is what I thought of. It's an old commercial. It's a little more positive than toxic gas, but just thinking about, how this all works, I don't know if you remember this commercial. I don't even remember who it was for, but it was about shampoo, and it was about a girl using...
Really? Shampoo?
Yep.
You talking to me?
Yeah, a girl uses this shampoo, and she thinks it's so great, so she tells two friends, and those two friends, and they're showing how everyone keeps telling someone, and then the next thing you know, 100 people know. It's the exact same thing with these asymptomatic people, especially healthcare workers, because we know that they're likely being exposed to it. So it's very likely that they are indeed asymptomatic and carriers. All right, so let's kind of get into the paper. All right, so what to be solved? We were the authors wanted to report the baseline prevalence of the SARS-CoV-2 infection in previously undiagnosed healthcare workers and non-healthcare workers that were recruited in a prospective observational study conducted within a major university, including an academic medical center located in New Jersey. New Jersey was one of the early U.S. epicenters of the pandemic, so they would have a good population to test. All right. How did they do it? Well, they created the Rutgers Corona cohort RCC, and they actually wanted to characterize factors related to the SARS-CoV-2 viral transmission and disease severity in the healthcare workers and non-healthcare workers. That was their primary goal. 2 was to determine the incidence of the SARS-CoV-2 and COVID-19 in healthcare workers and non-healthcare workers over a 6-month period. They sent out emails and to the university as well as to the medical center to be able to get people who would come in, and they had some criteria that they were going to be looking at, and we'll get into that. But specifically, they were trying to get at least 500 healthcare workers and 250 non-healthcare workers. Okay, and it would be from those 2 particular sources.
So it's kind of interesting because it's a single university with an academic medical center in one component of, or one side of it, and on the other side, the non-medical remainder of the university with just a standard, typical university with professors and students, and teachers, and so forth.
All the people that would be there.
Right, faculty assistant and so forth. But they didn't intermingle between the healthcare worker side of it, the medical side of it, and the non-medical side of it, which I thought was interesting.
Well, and I think that their criteria, they were really trying to be specific in looking at the risk of someone who is truly a healthcare worker and someone who is not. And so in a university, of course, even when you have this medical center, you are going to have some people that are very unlikely to have anything to do with caring for patients, right? An English professor or a secretary or a student, whatever. But those could, they had a large pool to that really could be represented. What's the word?
Representative?
That's the word.
Yes.
Man, I'm
okay.
struggling. Of the community itself. So I thought that was actually a really great way to try to get their study population.
Yeah, I think that was very well done in that regard. I do.
Yeah. Okay, so let's kind of look at some of.
I heard they had I remember reading that they had a very, almost such a robust response to it that they had too many responses.
They had to turn it off and
they
say,
had to stop, yeah.
Yeah, we can't do it. We weren't able to handle the intake of the people and the data. So yeah, so that's good.
Because people wanted to know if they were infected.
Right,
Yeah.
right. Okay, so here's how they did it. So they had a screener that went out, and it was an email invitation that then took you through some questionnaire qualifiers, and they screened 3,094. 934 of them were ineligible, and then they kind of broke it down. You can see here they had healthcare workers with regular patient contact. That was one of the criteria, almost 1,500, and then non-healthcare workers with absolutely no patient contact, around 800. Then they had to eliminate some for no baseline visits scheduled. In other words, the people didn't come in, so they had to get rid of about 800 of those. And then about 500 of the non-healthcare workers they had to go ahead and eliminate. So everyone who went through all the things they needed to do to be included in the study ended up with 546 healthcare workers and 283 non-healthcare workers, and really they hit their goal pretty well. They were looking for 500 and 250, so that worked out
they
well.
went a little over their goal, so
Yeah.
they did really well there.
They did well there. All right. So then here's their first table, and so this is just general demographics. You can see that the first category breaks it down by the demographic characteristic. Second category or column is the total cohort, which is 829. Then the next one is HCW, which is going to be healthcare workers, and then NHCW, which is non-healthcare workers. They looked at everything from the basics of sex, age, race, to whether or not they smoked. Then they looked into social distancing, which this was pretty early on, so this was great that they were already considering this to be an important component. You know, whether you worked on site at a hospital or university in the prior week that you were going to have your baseline visit, if you stayed at home as much as possible when you're not working, if you avoided being around other people as much as possible, and if you had a recent exposure outside of work to someone that was COVID positive or had new fever, cough, or shortness of breath. So they really were trying to get the cleanest sample group, I think, that they could. Now, this was a little bit of a long table, so it continued. The clinical characteristics, did you have any chronic comorbidity like diabetes, hypertension, coronary or cerebral vascular disease?
Obesity.
Yeah, obesity.
It's surprising to me at any chronic comorbidity, you've got 34 and 35%.
Somebody had something, right?
Yeah, that's amazing.
Yeah, and if you had any symptoms within the last week, okay? All right, then they looked at, so what they were looking at here, this is the table where they're starting to kind of get some of the results. They were looking at their looking at the infection rate of healthcare workers in 2 New Jersey hospitals. The Robert Wood Johnson University Hospital, and they abbreviated it there, and the University Hospital Newark. And you can see that they broke it down by healthcare role, whether you're an attending physician, a resident or fellow, a nurse, or other. So I guess we would be other, right?
Yeah, I think so.
Yeah. What unit you worked in, you know, whether it was a COVID unit, operating room, medical floor, emergency department, etc. And then the percentage of time that you had to spend in the patient's room. Because, of course, that makes sense. The more you are exposed to it, the more opportunity that you have to get it, right? All right. Okay, and then it continued on. This is the same table, just a little bit long, of estimated percentage of patients for which PPE was used. So, of course, you know, PPE is going to protect you, but if you are requiring PPE, that means you have a patient that is likely infectious, so that plays a role in it too, right? Your average number of patients with suspected or confirmed COVID per shift. Then here's an interesting chart that goes over the prevalence in comparison to first category A would be prevalence of positive cases, rather, in the 2 counties. Then category B would be for each of the participating hospitals in the study. And then C for the proportion of positive tests in their study subjects. And so you can see that if the community had an increase, then at the UHN hospital, they also had an increase. They had a very similar trend to the county had an increase, the hospital had an increase, and their particular study subjects that were from that location had an increase. The Middlesex and then also the other hospital, RWJUH, trended together for community versus hospital infections, but you can see that that particular hospital had a more blunted, although it did rise, it was much more blunted for their positive study subjects.
But the non-HCW, I mean, it's amazing.
Yes.
At how, I mean, this is what part of this whole article
is worth talking about. Yeah,
it really is.
Yeah, yeah.
And it made me, it really changed, because my opinion, I said this from the very beginning, my anecdotal opinion, my observation was that why are healthcare workers not getting infected nearly at the rate of what I'm seeing these people coming in as. And fundamentally, I was just
Well, especially
wrong
when we have
what
those,
I saw.
you know, we have
What I
those
believe I saw.
families come in, and maybe one of them is critically ill, but you hear that everyone in the family got it. You know, husband, wife, children, aunt, grandma, everybody has it. And we're, you know, basically around each other the way a family would be when we're working in these units. And you know, some people have gotten infected. They had to. So it would be surprising that we're not all getting infected just from our interactions with each other. Because I don't know about you, but as soon as in the beginning, as soon as I was coming out of those COVID rooms, you were taking off your N90 mask, and you're taking everything off to get your regular mask on, and of course you're around other workers at that time, right?
Yes.
Yeah.
Absolutely. But are we getting it from? Yeah, go ahead, John.
Yeah. Do you have a comment?
Hey guys, how's it going? Good. Happy New Year. I haven't talked to you guys since we got a new year here.
Yeah.
But,
Happy New Year.
I just had a quick thing. I was wondering, the time frame that they're doing this is about March to April, I think, right?
Yeah, like a
And
2-week time period.
How many of these non-healthcare workers were people who lost their job and pretty much quarantined themselves at home because they weren't they stayed at home. Everybody was scared out of their mind to go out. Is there any information on, once they enrolled in the study, did they, a lot of them lose their job and stay home and didn't really mingle too much with the outside public?
Well,
Yeah.
Can I answer that?
Yeah, please.
So, John, actually what they did was this was all, the non-healthcare workers were university employees. So they were mostly university faculty or faculty assistants of some sort. I don't think they were students. I don't believe they were students.
They were student workers.
Student workers, right.
Yeah.
But they were so faculty assistants is what I call those, but
yeah.
student workers. So they were all employed. Now, some of them were working from home, but all of the non-healthcare workers in this particular study that I understood the paper to say were people who were actually employed actively currently by the university, but they were more representative of the general population and not a healthcare worker with direct patient contact.
Right, and just to go over real quick a couple things here, and I can't remember if I have a chart for it. No, I don't. Okay, so I'll just talk about it. So specifically, since you're asking about the study population, these were some of the things they looked at. You had to, for a healthcare worker, you had to work at least 20 hours weekly in a hospital. You had to have an occupation with direct patient care and regular patient contact. Now, for the non-healthcare workers, they were, employees of the university in some manner. But they also had to have absolutely zero patient contact, but they had to be working greater than 20 hours a week.
Right.
So they were trying to keep the parameters the same on both sides.
Yeah, with the only variable being direct patient contact.
Right.
In a healthcare environment.
And I get your point, John. It's not ideal because sure, if you're working in a hospital, you just generally speaking are likely to have more exposure than someone who say works in a specific department at a university, and you're going to have a limited amount of people that you're interacting with. But I still think that it's worthwhile to, that they thought about this and considered this, and we're already thinking, how is this going to impact our healthcare workforce?
Yes, because without us, the whole system was going to crumble.
Right.
And there's been other studies also done, I don't know, I'm assuming you referenced it towards the end, that validate what they're saying. And again, this is completely contrary to what I believe these eyes actually saw at work.
Okay, so let's kind of, that's all the data I have from this, and so let's kind of just get to the author's conclusions, and they sum it up nicely, so I'm just going to read it to you here. So in summary, this was a prospective cohort of individuals previously undiagnosed with SARS-CoV-2 conducted in the early phases of the community transmission. The prevalence of active SARS-CoV-2 infection at baseline was considerable higher. I think that
considerably.
I think they
meant.
made a typo. Considerably higher among healthcare workers as compared to non-healthcare workers. We observed higher rates of infection among nurses and those caring for more patients with suspected or confirmed COVID-19, and then with the hospital that had the higher proportions of patients with COVID-19, which all of this is common sense.
That's why you saw that different slope.
Right, so they probably had more. Lower rates of reported PPE did not appear to correspond to higher rates of infection. Most infected participants reported no symptoms of COVID-19 and had no known sick contacts outside of the workplace. Additional strategies are needed to protect these critical frontline workers and to identify deficiencies in current protections. This prospective healthcare worker cohort provides the baseline data that will be used to study the incidence and other risk factors in SARS-CoV-2 infection in this crucial population as the pandemic continues. Follow-up of this cohort, including serial SARS-CoV-2 viral antibody testing, is underway. And just for real quick, sometimes I don't get hung up on the numbers too much, but I think this one is worth talking specifically about what they found. Overall, 40 of the healthcare workers, remember we had 546, which is 7.3%, were undiagnosed, asymptomatic. In the non-healthcare workers, only 1.4%. It's a sevenfold greater risk that's
or sevenfold increased incidence.
Yes.
Of being an asymptomatic carrier if you're a healthcare worker versus a non-healthcare worker.
Right.
Which that's very important information.
Yes.
That's really, and it's significant, very interesting. I did want to talk, and John, I want to pull you in on this conversation because something you just said and what's in this thing, the lower rates of infection not being seen with or without PPE, that PPE didn't really have an effect on the rates of infection, which I find
go ahead and
really
talk about that, because there was
fascinating.
something that I was going to bring up about that that you just
So I'm going to ask John, and then I'm going to ask you as well after you look that up. John, how, because I know you've seen a lot of this COVID, right? You've done a lot of COVID ECMO, okay? And we even had a presentation on whether or not SARS-CoV-2 would be expelled from the exhaust of the oxygenator, right? But were you, really my question is, were you highly compliant, moderately compliant, or not compliant at all when it came to N95 masks and the shield and putting on a PAPR suit, or making sure, basically with the full gamut of PPE, were you highly compliant, moderately compliant, or low compliant?
Well, that's a great question. I can tell you without any question I was 100% compliant, and I still am. And it's interesting, Joe, that now that things have evolved, Joe and Tammy, now that things have evolved, when we have these patients who come in and they're positive, and then on ECMO they're with us for weeks and weeks, eventually they begin to test negative. If a patient is tested negative at least 2 or 3 times, I personally, and this is not what everybody's doing, I treat them as negative. I wear less PPE. I will not wear my North mask. I will wear a regular mask. If someone's negative, I'm personally treating them as negative. Not to be negative at least 2 or 3 times. But if somebody's positive, I've been 100% on the North mask at all times. I don't even stick my head in the room. And you see a lot of this now. I'm sure you guys too. Oh, I just need to hand you something. They'll step 2 feet inside the room, hand somebody and run out. And they really don't have any PPE on at all, other than the regular, surgical mask that does nothing. And I believe it or not, now it's been 9 or 10 months we've been dealing with this, and I got my antibody tested just as my own self knowledge, and I'm antibody negative. So apparently I've never been exposed enough to develop any antibodies. I've never been symptom as well. But everybody that I see is pretty 100% when they go in the room. Now with the patients that are 1 time negative, 2 times negative, I see people who will run in the room real quick, run out again, things like that. And with me, if they're 2 or 3 times negative, I'm personally treating them as if they're negative.
Well-
how were you, I'm sorry, go ahead.
Well, I was going to say, I think that's kind of what we're doing as well, or, you know, a certain amount of time out, you know. I think I heard someone say the other day, well, we're 21 days out from, you know, this patient.
They're saying
positive.
10 now.
Yeah, but this was specifically what happened to me
From
last
onset of
week.
symptoms.
You know, I showed up to a patient that we've had, and I said, oh, you know, you're not in your gown. What are we doing? Because we still had all the PPE, you know, outside of the room, and they said, oh, you know, this patient is 21 days out, so, you know, we treat him as negative now. So, but I do find this a little interesting, and it kind of goes into what John's talking about being 100% compliant. I know in the beginning, those doors were closed immediately. We had the negative pressure. The hospitals that didn't have enough negative pressure rooms were piping in things to make sure that we had the negative pressure. And I did notice over time, the more we had more patients, that the nurses themselves weren't necessarily always compliant with, oh, the door's closed, or, you know, the door slid closed, and you know, sitting ECMO, you're sitting there, you're watching this, and sometimes you don't have a lot to do. So
We saw over time a degradation in compliance, I believe is what you're trying to say.
Yes, that's what I'm getting at.
Yeah. Well, so same question to you that I asked John. Over the course of this whole thing, have you been highly compliant, moderately compliant, or low compliant when it came to the gamut of PPE, the full court press of PPE, the N95, I mean, you can include or exclude the PAPR suit, but the N95, the face shield, the gown, the gloves, the whole thing. Were you in that same? Were you high, medium, moderate, or low?
I was high, and I think
High.
I still am to a degree. Even once a patient is negative, I am sometimes wearing an N95. It really just depends on how close I'm going to have to get in there. You know, if we're really like getting in there and we're turning the patient and we're cleaning the patient and I'm going to be very close to them, I often will go ahead and put my N95 on. I always have my goggles on, and I'm cleaning my shoes before I come out of the room, and if I'm going to touch anything other than the knobs on our ECMO, I'm putting a gown on as well.
I've been, you know, and I've been.
Because for one thing, I'm then going from outside the room to sit in a chair, kind of in a community area where lots of people are going to be coming and going. I think that, I mean, I'd be very irresponsible if I wasn't compliant, even for my own health. But that I might have
COVID germs.
I might have the COVIDs all
might
over
have
me.
the COVIDs all over you.
Yeah.
Yeah, I hear you. Yeah, I can't say. I think that I was. Poorly compliant.
Really?
I do. I was poorly compliant from the beginning.
In what way? The N95?
Yes.
Okay. I didn't really
In
wear
particular, the N95. And actually, I don't know if you're experiencing this, John. If you're experiencing this, please forgive me for interrupting you.
No problem.
But I have started to develop chronic sinusitis from having this mask on all of the time, and it's starting to really bother me.
Well, I have had to switch masks. Used to, I didn't really care if I was with the standard mask, the circle one, or the new duckbill one.
Yeah.
You know, I didn't care. Whatever the hospital gave me was fine. But I've noticed that when I wear the appropriate standard mask, the one that I was fit tested for, it fits my face.
Yeah.
That my skin is breaking down right here because I guess it's just so often we're having to put them on and leave them on for, you know, a length of time, especially if I'm in a COVID wing. A lot of times I'll do my entire shift in one of those, and my skin's peeling off right there.
I saw a nurse the other day. She was using foam tape on her nose and on her cheeks where the N95 mask went to for that same reason.
Well, and a lot
she actually had, like, you could actually see that she had what looked like pressure injury to her face.
A lot of the nurses I've noticed too, they have these, I guess it's kind of like a Band-Aid without the padding. It's just like a sticker that goes right here to protect their nose as well. So, yeah.
But according to the article, according to the paper,
well, but
there was, go ahead.
Let me read this a little bit to you. So 43% of the healthcare workers reported using PPE during all patient contacts. So that's, a little less than half. 10.5% of those tested positive for COVID. The rates of the COVID infection were slightly higher among workers who spent greater proportions of their time in the room. That's one qualifier, and reported higher levels of PPE use, and reported exposure to more patients with suspected or diagnosed COVID. So I took this to be, it's not just whether or not you were compliant, it was that you used more PPE, and more PPE is going to be used if you are exposed to more patients that are suspected or confirmed, right?
But you're still talking about 10.5%.
Yeah.
It's not 100%, so I will give you that.
Yeah.
But can you really attribute that to, what do you attribute it to? Do you attribute it to poorly fitted PPE? Do you attribute it to improperly utilized PPE?
I don't know. Maybe their nose was out, like everybody at the grocery store.
Right, yeah, the PPE, anesthesia-style mask wearing, that PPE doesn't actually work. What is this attributed to? Because if you're that compliant with PPE, and 10.5% of that population of people is still getting infected, then that's 10.5% of the people who either one or the other, or a combination of all, that the PPE was improperly used, the PPE was or not effective, was improperly used, or inefficiently used, or they were or it didn't work. And I think that kind of goes full circle.
Yeah.
John, I'll throw this out at you.
Well,
It goes full circle to, and I don't mean to interrupt you. Well, you could give us both thoughts, but they said in the beginning that masks are not going to help us, and then masks were the only way to go, and you have to have masks, and now they're sort of easing the mask thing again, and there's been a lot of inconsistent guidance from the experts that we have to rely on as to what does and doesn't work. I simply don't know.
Yeah.
We got vaccinated. Have you been vaccinated, John?
no, the backlog is so high now. I stepped back in the beginning and let a lot of the frontline ER people, ICU nurses that were with the patients 12 hours a day, and the real top front lines go first. And now I'm looking to get it done, and we don't have as many vaccines in the hospital like we did at one point, because we're a distribution center, but the amount of vaccines used to be just be able to walk down and get it. Now I think they're only giving vaccines 2 hours a day, Monday through Friday.
Yeah, we've seen a little bit of that too. So Joe and I got ours pretty much, I think they arrived in Houston on a Wednesday and we got ours on a Friday. So we were pretty early on, and it was real easy. You just they were there all day, and you just walked up and you got it. But there were some of our employees that, lagged a little bit, due to scheduling or whatever, and then
they ran out.
And so they ran out, and so we had to find other places for our employees to get them. And even some of the hospitals here that are, the larger distribution centers had opened it up to some of the, the 1B qualifiers and stuff, and they've had to pull back from that, and now they're just with healthcare workers and over 65.
Right.
Because they've just run out. They had an incredible response.
But Houston, I think, in compliments to Houston, I don't know how Orlando ran for you guys, but in compliments to Houston, I have to say, because there was a line today at St. Luke's, the Woodlands. The other day I saw that line, same line at Memorial, the Woodlands. Yep. And I know Methodist, the Woodlands, is exactly the same. They have the parking lot with cars just lined up, just in a zigzag form.
Yeah, they're doing drive-thrus.
And they're just driving through and just pow, right in the window. Boom, you're done. Go. You're done. Boom, boom, boom. So I really see Houston as being very effective and efficient.
Yeah, I
with
think
this.
they've been very efficient as well. But at the same time, initially, I know a couple of the hospitals were opening it up to, the even family members, priority
Yes.
family members, if they qualified, either age or 1B qualification. But they had to, and the main reason for that was there was a lag in employees who wanted to get the vaccine. And so they had all this extra vaccine, and so they opened it up, to their employee family, if you will. But then they had such an incredible response from that, that just from the people, I guess, who had, who got the vaccine and then wanted their family members to get the vaccine, that they had to then cut that off. But
well, I mean, we saw it in the news. You saw healthcare workers, physicians, who actually in the study had the lowest risk of contracting the disease. The nurse at the bedside
had the highest.
Yes.
Yes.
And I think that does not surprise me at all.
They spend the most time with the one-on-one.
Up front and personal.
Absolutely.
All the time. It's amazing. And, I've said this at the hospitals that we service. John, I'm assuming your experience in Orlando is the same. I have always respected what nurses do. But I got to tell you, through this pandemic, I have not gained a respect or a renewed respect, but certainly have increased significantly the respect I already had for them, because they have sacrificed unbelievably, the exhaustion and the look. When we get our I don't know what you're experiencing there, John. We need to hear from you. I need to stop talking maybe, but
it's not going to happen.
I know it's really hard for me to do, but and the more tired I am, the more I talk. But I have not been impressed with our ECMO survival data for COVID COVID-associated lung failure, pulmonary failure. In the early days of it, it was better, but over time I've seen it really diminish in our successes, and we have had it's demoralizing to see what has happened. And I don't know whether that's delayed treatment. I don't know if it's just an overwhelmed system and we can't, manage it. I don't know if it's because there's some mutation that didn't was taken into consideration. I don't know the reason for it, but we have seen a lot of patients succumb to this disease from their lungs becoming fibrotic, stiff, and ultimately unrecoverable.
Yeah, I think everything you guys said, Houston, is so similar to what we're seeing here. It's initially there was plenty of vaccines, you could go get it. I think a certain hefty percentage of healthcare workers kind of held back and said, I'm going to wait and see, how this turns out. And other people ran down to get it, and then you could go get it. Now it's over 65 and healthcare frontline only. And if you're 60 years old, you can't even get yourself on a list. If you're a regular citizen, you can't even get yourself on a list if you're not 65 out there. And it's hard to do it even if you're over 65, because we've been trying with our moms and elders that we have, and it's not easy to get on a list. So same thing that I think you're seeing, but I think we're seeing failure fatigue, Joe and Tammy. In other words, we were so energetic and we tackled these patients, and in our center, and I think some centers where you were, we saw a fair amount of success, and it was encouraging. And I think now we were tired, we're beat up. The patients seem to come in, we seem to get stuck meaning they're not going to get better, they're not a candidate for anything, and they're on ECMO.
And they're not necessarily
their
getting
lungs
worse.
Are fibrotic and they're stuck, and if we get them off ECMO, it's at a high CO2, and they're breathing like crazy on their own, and there they lie. It feels like a gut punch that keeps coming every time you go back in for another one. So I don't know what our numbers are now. We've treated so many patients. I'd have to see what the numbers are. I think we were, well above 55 or 60% success. I don't know what it is now. And then on
we're
top
not
of it,
anywhere close to
not
that.
maybe,
No.
but definitely been evolutions of the virus, both better forms and worse forms of the virus, I think, have come along.
Mm-hmm.
You know?
Well,
Yeah.
if I may add to that, I also think that there's been recently quite a few that we know aren't candidates, but you know, doctors are so discouraged knowing the fate of this person, this young person, you know.
And they're usually not a candidate because of obesity.
Correct.
They fall outside of our protocol
But
window.
they, you know, you hate to see a 40-year-old, a 29-year-old, a 30-year-old, and just say, this is it. There's nothing else we can do.
Mm-hmm.
And so we're doing some of those because doctors are also, you know, mentally worn down with all the failures and to be able to help these people.
And having to make those announcements.
Yeah.
Look, let me tell you, and you just bring up, go ahead, John. I'll let you go first.
Yeah, I wanted to say about the use of the PPE. So you guys know, I'm sure, how does the N95 mask get its name, right? It's only 95%
95%,
effective.
right.
Right.
So if you have 10% of what the study showed, 10% of the high exposure nurses getting it, that's a product of the 5% failure, but except they're in front of the person, near the person so often that it's probably a little bit higher.
Yeah.
But I'm a little bit shocked that only 43% of people, nurses, reported using the proper PPE 100% of the time. I'm surprised it's not a lot higher than that.
I
myself.
saw a lot higher compliance with the places we go.
I did and didn't. Both. I did and didn't. I saw, you know, in the very beginning when I was going to the medical center at that one particular hospital, and they're in their COVID unit, they actually had monitors on both sides because it was a two-sided setup, and their only job was to observe people going in and out of a patient's room, and if they were not 100% compliant with their PPE, intervening and making them do so.
Well, I know early on in the first surge, we were even doing, some hospitals were doing all med pumps are outside of the room on these incredibly long, you know, lines. And, you know, that you were only going in the room for the patient, just like the absolute minimum amount. And in fact, one of the patients I cannulated for ECMO was at a smaller community hospital, and so they don't really have a large ECMO program. We were going to put them on ECMO, and then, you know, they were going to be transferred out at some point.
In a small ambulance with very confined quarters.
Exactly. No matter how many times you tell them
that makes a lot of sense.
Doesn't work. But anyway, I was just trying to find out the patient. What was the deal? I was just trying to find out something about the patient, and I said, oh, you know, oh no, you know what? I had been doing an ECMO, but then there was another patient that we were going to do some kind of surgery on. That's what it was. Because I'm like, how did I talk to the patient? Because we wouldn't be talking to an ECMO patient. That's what it was. And I wanted to, but he was COVID positive, and he was in the COVID wing, and I wanted to just ask him a question. I think he was Jehovah's Witness maybe, and I was trying to kind of find out the parameters. I was not allowed to go into the room. We had to call the phone. The patient had to answer the phone. Then the patient doesn't speak English very well. And so then we had to get the translator who then went to the phone. It was just this big thing. And I'm like, I have an N95 mask. Why can't I just, you know, go in there with the translator and just ask this simple question?
Yeah,
no,
I'm not going to go smell his breath.
Right. And they're like, no, we can't go in the room. I'm like, I'm about to be in an operating room with him, so I don't really know
Understand that.
but
It didn't make sense. Doesn't
Guys,
make sense to me either.
if I would say this, I have seen a decrease in compliance, even myself guilty, and the use of the gown. Always wear gloves and always wear the North mask. The North mask is like wearing a dive mask, right? It's uncomfortable. And by the way, for anybody listening who doesn't know, there is nothing comfortable about any of these masks. And the duckbill mask, I tried it. I don't think it makes a seal. I felt my my exhaust breathing going up and hitting my eyes and stuff. I don't think it was even making a seal. So there's nothing comfortable about the N95. And if you've ever been snorkeling or diving, this is what these other masks are like. They you know, to wear them properly, I don't know how you can wear it for more than 30 minutes or an hour and not go crazy. But anyway, so we're constantly adjusting them and playing with them. At least I am, and people I see. But the thing answer me this: we go in the room to transport a patient, and everybody puts on gown and gloves and mask. We step 2 feet outside the room, and all the gowns come off. We then transport the patient through hallways, which, when it first started, you talk about strict.
Yeah.
It took a team of security to barricade the doors. Now we pass families, visitors wearing, the regular hospital mask. We go right by other hospital workers. We're wearing our North mask, but other people are passing right by. And then we go down, we do a CT. We put the gowns back on for 5 minutes. We take the gowns back off when we leave the CT room. Do the same thing back. Once we get in the room, we put our gowns back on again. Are you guys doing that?
Yeah, it's something very similar when we're going down to CT. I mean, I'm wearing my N95 and I've got my double gloves on and I'm doing all that, and we're wheeling the patients just through the entire hallway.
Yes,
into the elevator.
It doesn't make sense.
But I mean, I don't know what the solution is.
Yeah, there is no solution. You got to take care of the patient. The patient needs a CT. You'd have to put them in a bubble.
Yeah.
So we'd have to use the Defense Production Act and make some kind of a big bubble for the patient that is a closed
have you seen those
ventilatory
that
system.
Clear bubble thing you can get in, like at the mall?
Yes.
And we could do that.
Like a hamster.
Yeah, we could all be in one.
I think that'd be great. I think that'd be very interesting to wheel a gurney down like that with an ECMO attached to it. I think it'd be fantastic.
Super.
Coming outside of the bubble.
Yeah.
So and somebody would have to push that along and keep up. I could just imagine
I mean,
how
it's
that
hard
would
enough
go.
to keep up with just someone pushing, someone pulling, all of that.
That's own effort.
Although this is all very interesting, I have a couple things I wanted to get to as far as.
Oh, please forgive me.
Yeah, no, it's okay. There are just a couple things to consider. Okay, so this is what I wanted to talk about: just the COVID lasting effects on healthcare jobs, and these are some of the things I thought we need to kind of think about. So, what are the new expectations from healthcare workers going to be? Should they get hazard pay? Should they get workers' compensation for contracting COVID at the workplace? Because
Should firemen who had to go and policemen who had to go fight the Twin Towers with that battle of fire and death?
No, I know. And normally workers, I don't know a lot about workers' compensation, but I did look up a little bit. Normally, a healthcare worker in their everyday kind of job responsibilities, if they contract something that is the flu or whatever, some kind of infectious disease, it's not covered under workers' compensation.
No, and I'm gonna speak to that here in a moment. But go ahead and give my opinion.
And then just the extreme mental stressors that are going on with working more, right? Because we've got less healthcare workers, and I'll get to why we have less healthcare workers in hospitals right now later. But not wanting to say no, because you have a personal responsibility to try to go take care of these patients, or maybe your spouse is not working because of the pandemic, and so you need those extra hours, and you're just exposed to all of this increased death, increased just futility of treating so many patients that just don't get better.
Absolutely.
And then, what other things are healthcare workers going to start considering?
I think we're all going to suffer PTSD when this is over with.
Right.
I think we're suffering from it now.
Yeah, so are we going to require that we get some kind of mental health support? I mean, are we, what's going to be done about the lasting effects of how this is going to change job expectations from healthcare workers? And then going on to the other side of it, what about from healthcare employers? Are we going to require vaccinations? And I want to talk more about that, so don't get too far on that. Are we going to require increased responsibilities per employee? The ratio of a healthcare worker to a patient. Normally it's this 1-to-1, 2-to-3, whatever.
1-to-1 or 1-to-2.
Or sometimes it's 1-to-3,
If they're easy patients.
Yeah, but
But now they're not.
Right. So is that going to change? Is that going to change the standard because you did it during the pandemic? Is this what we're going to do, moving forward? And part of that has to do with the shortage of healthcare workers.
I don't think so, and very quickly I'll say why, and that is because it is absolutely decimating our ranks.
Yeah.
There's only so long you can you can do this to people, whether it be healthcare workers, whether it be the military. It doesn't matter what job it is. There comes a point where you just exhaust the human asset resources that you have, and they can't go on any longer. So we're being pushed to an absolute limit. But will that reset the bar? I don't believe so.
And then what about employment contracts? Now, sure, those exist already, but I'm speaking specifically to, when we start hiring, if you're an employer, healthcare workers, are you going to have some sort of clause about having to stay? I mean, we are experiencing in Houston, I'm sure you are in Orlando as well, I think it's going on across the country, where healthcare workers, we're specifically talking about nurses just because that's who we're exposed to, but it could really be, anyone. It could be perfusionists, it could be doctors who are leaving their established facilities to be able to do these traveling things because they're paying so much more.
Yes.
But then that leaves the facilities with the inability to care for the patients that they have, which goes back to the increased responsibilities.
Absolutely.
And so it really has
Absolutely.
started kind of an avalanche, and that's going to be a real problem. Because then if you don't have enough of the staff, you're not able to do the limited surgeries that you're doing, and then those patients are getting sicker.
It's very bad. Go ahead, John.
And in our COVID ICU, which used to be ECMO only before COVID, but now it's pretty much ECMO COVID ICU, the turnover in nurses has been absolutely dizzying. In the 90 days, or in a 12 to 18 month period, we have seen a 90% or so turnover in nurses in our ECMO ICU unit.
Wow.
And something left on my computer here, but anyway, it's unbelievable the turnover that we've seen. Not so much in the OR, but I know in the unit, it's been incredible. Now I know a experienced scrub tech, cardiac experienced scrub tech here in Orlando, that is going to Austin, Texas, to take a job, and is getting 5 times the salary. And this is not an agency pay job; it's a hospital staff job. Claims he's getting 5 times.
Well, he's claiming that. John, I put a grain of salt in that.
Well,
I don't even believe that.
I don't know. I might believe it because I looked up some of this stuff about nursing. I just looked up nursing specifically because there's a lot more articles that have been written about this, that you want to get, a nurse to come help you with your COVID patients. Depending on the part of the country, it's $5,000 to $8,000 a week to get that nurse. That's incredible.
That's a lot of money.
You're talking about 4 times or 5 times the pay that they are getting. Now that might be agency with no benefits plus travel, and that was a while ago. But New York, California, and Texas, you guys are getting cream there apparently with normal caseload combined with COVID caseload, right? And apparently it's probably the whole state of Texas, because you guys are in Houston, but this was in Austin, and I don't think that the gentleman was lying. He might have been exaggerating a little bit, but those are his words. I mean, I asked him point blank.
I wouldn't say he was lying. I wouldn't say he was lying, but for how long, John? Maybe for how long?
That's the point.
But he's as a hospital staff employee to be a scrub tech.
That's not going to stay like that. The market won't bear. The market won't bear it.
Well, and specifically in Houston, since it's such a large place and there's lots of hospitals, and we have shortages here right now because of everything that's going on. Because of all the things.
No, we have shortages of everything. Everyone.
Yeah.
Every single discipline you can think of.
Talking to a nurse specifically who loves her job. She likes working there, but I was like, can you believe these people giving up this good job at this reputable place, et cetera? And she said, actually I can, because I'm almost feeling like a fool that I'm not doing something about it for my family when I can make, this much more money, and I can, pay off my car in a month or whatever.
mhm.
And I said, yeah, but you have to travel. You have to be away from your baby. And she said, no, I don't. I can stay right here, take a job somewhere else, and I travel just across the city. And they're still getting that kind of pay.
Right,
So
right.
even if you're getting travel allowance, some of these people aren't really traveling.
Right.
They're still staying at home.
Mm-hmm. And I think there's, of course, well, I've got some things to say about
Okay,
this.
that's it. That's all I had. I just thought those were some interesting
Thank you.
things.
Mhm.
To
Now let's talk about it. What have we been doing for the past hour?
That's my closing slide.
Gotcha. Okay. Well, that's part of who you are.
That's part of who I am.
So, a couple of things I wanted to go over. Can you go back to your? Can you go back to the second to last slide, please?
Oh, the expectations.
No, the second to last slide,
here, I
not
can
the
do it.
first slide.
Oh, here. That wasn't me. Wait, there we go. There.
Right there. Okay. Hazard pay, workers' compensation for
These are all the
something
things
you
that I
get,
found out there that
mental
people
health
are
support and other.
projecting that are going
Sure.
to
I mean, I think
be
these are,
expectations.
well, or something to consider, right?
Yeah.
I agree. So I'll talk about that first. We are all in healthcare. We are volunteers in this army. No one is making us be frontline healthcare workers taking care of these COVID patients. We have chosen to do this. We get into healthcare for a variety of reasons, right? Usually the most prevalent reason that people say they are going into healthcare is because they want to help people.
Right.
They have a calling. They want to help people. But, I've been doing this job now. I had this conversation. I think I might have had it with you
We
just
had
the
it.
other
Yeah,
day.
we had it.
I've been doing this job now for 43 years. That's a very long time. That's 2 lifetimes, really, when you think of career lifetimes, work lifetimes. It's a long time. And I've seen a lot. But in that period of time, I have only been confronted with situations like this, where your conduct will define you for the remainder of whatever your career is, that will be who you are. And that's what happened, of course, in 9/11 with those firemen going up those stairs, knowing that building was probably going to come down, but they kept going up those stairs to save a person.
Yeah.
And they died. So in the 43 years I've been doing this, there's only been, for me personally, fewer than a whole handful of fingers. In other words, a hand with some amputation of some digits. Opportunities.
Not folded down.
Oh, okay, folded down. Opportunity
So dark.
or circumstances that met this type of character assessing or character exposing circumstance. And you have to make a decision when you're in this type of business where you're well thought of in the community, you have standing, you have people admire you, you get the, oh, wow, you do that. So you get all of that. We get paid very well for what we do. Everyone in healthcare, I think, actually, except nurses, I think, are grossly underpaid. But I think that
Like teachers.
Teachers are good teachers are grossly underpaid. Sure. That's why we have crappy teachers, but that's another topic for another day. But I think that, but again, they chose that profession, right? So, that's sort of how I feel about things like that. But you get confronted with a situation like this, and you have to make a decision. Am I going to run towards the danger, or am I going to turn tail and go the other way and run away from the danger? You have to make that decision. And that decision is going to be in your psyche. It will be your reputation. It will be what you think of yourself and others think of you in perpetuity. all of that stuff, workers' compensation, hazard pay, mental health support, I think that's reasonable. Mental health support, I think, is very reasonable. I think, look, so that leads to my second thought. So in terms of what a healthcare worker's responsibility is in a situation like this where we are putting our lives at risk to help others, is a moment in time that is what we got in this business for. Like whether it be law enforcement, military, I don't care what it is. That's not the time to cower in the corner. It's the time to get up and you do what you got to do. And that's what this is all supposed to be all about. I fundamentally, philosophically believe that to my absolute last, to the depths of my core. In terms of physicians and what they're going through right now, and they do it on a daily basis, but I was called by an intensivist. He came to see me along with a couple of nurses who I knew, and they said, look, we have a nurse who I knew in the waiting room with their, a small portion of their family, and they want to talk to you. And
you, Joe Basha.
Me. And I was a little bit like, me?
Yeah.
And they're like, well, if you don't feel comfortable, I said, but what do they want to talk to me about?
Yeah.
And so, and I like this person. I like this nurse. They're a good person. I know them pretty well, but I know them from work only. And so the nurse's brother, one brother had already died from COVID. They all got COVID.
Okay.
The other brother was transferred to our hospital for evaluation of ECMO, but we were out of ECMO pumps. We had no platform in which to put them on ECMO with.
Real quick, remember in the first surge, we got real close.
Very
but
close.
we never actually had no more pumps and candidates that were really
Correct.
should be given the option.
Absolutely. Well, this nurse asked me, said, look, I know you know people. Can you please find my brother a pump? We can't have another brother die. And I'm telling you, I found it. I found one. And I have to give my compliments. I will say where I got it from. I think that's reasonable. I won't say where I was at. But Memorial Children's gave me an ECMO pump. In the medical center, Texas Medical Center. Curtis Shelley got me that pump that I needed, and we got that patient on ECMO, and I believe he will be a survivor. I do believe he will be a survivor. But it was emotionally distressing for me making all the phone calls I was making while having to manage 3 other patients at the same time and stressing over them sitting in that waiting room praying I can help them find a pump, which I ultimately did. And I got to tell you, had I not been able to, I don't know how I would feel today. It was exhausting to me. But when they were saying this to me and crying, I had to reflect this is what physicians go through, and they have to go out there and say, look, we really need to consider compassionate care here. We need to do a DNR. We need to consider letting him go or her go or whomever it is, whether it's a mother, a father, a sister, a brother, a daughter, a son, whatever the case may be. Look, I tell you what, I'm still affected by it. And I think I'll be affected by this forever. But I think the people that lived through this, you, John, me, the ones that stayed where we were, that had a sense of loyalty and responsibility and actually did this job will be I think this will be a defining moment for all of us that went through this, like Katrina was for the people that were handbagging people. You could use that as an example as well. These are moments that are so rare and it's so critically important. So I didn't mean to go on my dissertation about how I feel about this, but I wanted to get it out and say it, and I've been thinking it for a long time, and I wanted to share it with the people that watch our program. So those are my thoughts.
Yeah, John, what about you?
Yeah, well, I mean, the hazard pay is starting to take care of itself. That's what we were talking about a minute ago.
Yeah.
You don't have to ask for hazard pay because over time, the wave of the crisis gets so big and the people available and willing to stay become smaller, not larger, and all of a sudden you're in hot commodity.
Yeah.
So now I think that's where we're seeing. I don't know in perfusion so much, but
Yeah.
nurses and other things, they're seeing. We have a lot of big time incentives now for nurses to come in, work more than their hours, to not use their PDO, and a lot of things like that. And
Right.
they're getting sizable weekly or bi-weekly bonuses on top of overtime to
Yes.
just come to work.
Well, I think they should, but I also believe that they are getting tripled frequently. Healthcare. You had mentioned about what do we do with people who they're not on call. We have had to. We as an organization, as a practice, we are so essential when you think about what we do that we have to be able to say we are on a wartime footing. This is a national disaster. All vacations, I'm sorry, are canceled, and there are no weekends off. Everyone is on call right now 24/7 until we get through this crisis. Those are realities that you have to do, because if you do not do that, think about what the consequences are. The consequences are death. This is serious. This isn't to be taken lightly, in my view. I think this is really being, used as this wedge to make money. And I'll tell you, I think nurses are grossly underpaid. I think we're underpaid. I think I'm underpaid. I don't get paid by the hospital. By volume, the company does make money. That's indisputable.
Yeah.
But they don't pay me. I can't go in there and say, well, we're working so hard and all of our hours are messed up and I haven't slept in 2 days, and so we have to charge you more for this procedure than we did last week. I can't do that. That's impossible. So there's a lot. You've run a business before, John. There's a lot of challenges that come with this, and but that's what I chose that. It's not anybody else's responsibility. It's not anybody else's fault. It's mine. That's my job, is to manage that and make it work and make sure that we fulfill our obligation to the patients we are charged with, have the responsibility of taking care of when they're just sick and they have no ability to help themselves anymore, and they need us. Completely helpless. Totally. Totally. And if you can't have compassion for that, you got to be in a different business. Loss prevention at Target, I know, is hiring all the time. That's where you need to be.
Yeah.
So are we,
we wrapped it up.
We wrapped that up? Okay.
We did.
Joe's diatribe. That's what we're going to start a program, Joe's
John,
diatribe.
this is what happens when you make Joe work a couple nights for you. He comes out
Come on.
a crazy man.
I've been pretty good. Okay, so now we're going to do something new and exciting, and this was completely John's concept. I have to give him tremendous compliments for this. And so we're going to be starting a new series that you'll see with each PerfWeb, with each Tammy Sparacino Journal Club. We're going to have the John Ingram's Knowledge Nuggets. And I think we have a little intro for it or something like that. Yeah. Okay. And I think that's going to come up, and then we'll be turning the floor over to Professor John Ingram. There you go. Hi, John.
Hi, John.
Hey, great. Okay.
That was great.
So, before we bring up the slides, we had this idea, ran it by both you guys. We want to keep it growing, the PerfWeb and the perfusion education format and reasons for people to tune in and learn. None of us are getting paid for this. people were all just doing voluntary. We want to give back to the field that I feel has given so much to me in my career. So came up with this little idea, and the big thing, you know, I think all three of us in the time we've spent together, we've had so many times where we're in the middle of a presentation, whether it's one of us or somebody, and we stop and we say, you know, this is a take-home slide. This is something that our audience, if you're listening and you're trying to figure out what can I do to be better tomorrow, this slide here, if you'll screenshot it, this is you know, some meat and potatoes of the presentation. And how many times have you guys been to a whole week, 2-3 day long meeting, and you come back from the meeting, or somebody of your coworkers come back from the meeting, you say, well, did you learn anything? And they give you maybe about 30 seconds worth of stuff, and then you're thinking, well, you just went to, you know, 30 lectures or so, and they're all 12 to 15 minute long. And
they went to 30
can't
seconds.
Just come back with anything, right?
They went to 30 seconds of a lecture and spent the rest of the time on the beach.
What
Not
I'm trying
always.
to do with this is do a short, powerful, you know, nugget of information that when people watch, our viewers watch, they can say, this I can use. I'm going to keep it short, sweet, impactful, to the point, and something that hopefully improves anybody who watches it either live or in the future. So we'll bring up the slides, and hopefully you guys will see what we mean. So this is the inaugural Knowledge Nuggets, episode 1. Today's January 28th, 2021, and I guess I'm going to be the host of this new little segue here, Joe, and I'm never going to have any disclosures on this lecture or any of the others that we're going to do. And so this week's topic, and every week is going to be different, but this week's topic is going to be vasoplegia. And our motto on this program that I came up with is spend a little time and expand your mind. So you can take home something of value by just spending a little bit of time watching this segment. So the format's going to will be a different topic each week or each episode. There's going to be some take-home slides, some take-home knowledge nuggets that you can that you're going to be able to do, and you're going to hopefully say to yourself, you know what, I can be a better clinician, a better perfusionist tomorrow. And what you're going to see is, go back a slide, guys. What you're going to see is when you see this little gold nugget, the shiny gold nugget up in the corner of the slide, when you see that symbol on any given slide, and I'll point it out to you, that's going to be your nugget, one of your knowledge gains, one of your knowledge nuggets, and that's going to be a take-home slide that you can take with you for this particular topic, okay? So we'll go to the next. And so this is kind of the idea that I had, Joe, and you guys can tell me if this is going to work, but to give our audience a general idea, it's going to be a highly impactful segment. You know, just like when you go to the meeting, it's a 12-minute or so presentation with 3 minutes of questions, so it'll be about 12 to 15 minutes long. And then I'm going to do a little thing at the end that we've never done before, and this is going to be a little surprise. Every segment will have a little surprise called the Perfusion Gem of the Week, and that's going to be a 2 to 3 little minute segment. We're going to talk about that more in a minute, and then we're going to have a panel discussion and questions, just like we always do. And then if you guys are listening either now live or in the future, you can reach me with comments, questions, or suggestions for a future program at the email there, john.ingram@perfweb.us. And I will be checking that daily, and I will get back to every single person who sends me an email. I will reply to. So getting on to today's topic, what is vasoplegia? So, you know, when you start to talk about vasoplegia, what occurred to me in this topic, because if you guys remember back, Defense Secretary Donald Rumsfeld, back in February of 2002, and I think this was in the lead-in to the Iran-Iraq war, I think is what it was. He came out and did a press conference, and what he said is now become famous. And he was trying to explain the limitations of the intelligence that we had about our bombing program that we're doing in Iraq. And amazingly, I've directly attached to this that, you know, he was trying to explain the limitations of the intelligence reports. He may have inadvertently described the current state of affairs when it comes to vasoplegia. And you'll see what I mean here. So what he said was, And this has to do with vasoplegia as far as how do we define it? What are the risk factors? What are the pathophysiology? What's causing it? And how to treat it? Well, there are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we don't know. But there are also unknown unknowns. The ones we don't know, we don't know. This is exactly the state of vasoplegia in our field today. So how do we define vasoplegia? And this has actually been a problem of people defining it different in the research. And really, you know, Joe and Tammy, this is something that didn't exist for the first 35 or 40 years of cardiac surgery. It was first described back in the mid to late 90s, and one of the very earliest papers that's given credit for that is Dr. Gomez and his associates published this in the Journal of Thoracic Cardiovascular Surgery in 1994, and he described this thing as vasoplegic syndrome, a new dilemma. And vasoplegic syndrome, now we sort of shortened it and call it just vasoplegia, but it literally means vascular paralysis. And it's referred to and has been referred to in the past as vasodilatory or distributive shock. So here's a golden nugget. It's a take-home slide. What is it characterized by? How do I know that my patient has vasoplegia, or maybe it's something else? Well, this is what it's characterized by. You're going to have a very low systemic vascular resistance, SVR, due to profound vasodilatation, not other things, profound vasodilatation. This vasodilatation is going to be refractory to high-dose vasopressors, meaning that you cannot seem to get this patient out of this vasodilatory state, even in the face of using high-dose vasopressors. And it's in the face of a normal cardiac function. The patient's cardiac function and cardiac index will either be normal or maybe even hyperdynamic, but yet you still have this low blood pressure. And the problem with all this is that it invariably leads to tissue and organ hypoperfusion. And how do you know that's happening? Because you're going to have increasing lactates. So this is when vasoplegia is encountered. The number one clinical situation that it's encountered in is septic shock. Number two, however, is post-cardiopulmonary bypass patients. Then it's also seen in general surgery occasionally, and it's also seen occasionally in burn and trauma patients. But this is hallmark. What is the hallmark of vasoplegia? And here again, a nice little knowledge nugget, take-home slide. This is what it's hallmarked by. You have vascular paralysis that is unresponsiveness to high-dose vasopressors, along with end-organ hypoperfusion in the presence of normal cardiac function. Here's another take-home slide. We have to be able to define that. It's nice that we just could lay it out in sentence form, but how do I know it? How do I know when I've seen it? Well, you're going to have a map, usually below 60. Some people use 70, but somewhere below 60 to 70 is your map, number one. But your cardiac index is greater than 2.5, so this is not a cardiac manifestation. You're going to have an SVR, systemic vascular resistance, lower than normal. Normal is generally 800 to 1200. Your SVR, when you do the calculation, will be below 800. And this all occurs in the face of 2 or more vasopressors. Now, you have to say that it has to be in the absence of an anaphylactic shock response or in the absence of hypovolemia. It can't be just that the patient needs a lot of volume. And it has to be in the absence of some state causing adrenal insufficiency. So what is the incidence of vasoplegia after cardiopulmonary bypass? Because even though those other surgical and clinical situations can cause vasoplegia, I'm going to focus now on, more relevant to our audience probably, is the incidence after cardiopulmonary bypass. Well, the incidence rate ranges somewhere between 9 to 44%. And again, this kind of happens because the way people defined it in the early days. And there's some of the references for you. And by the way, if you guys want more references, more details about these references, feel free to email me in that email that I showed earlier. But the accepted rate of incidence is 20%. 1 in 5 adult cardiopulmonary bypass patients experience a pretty severe form of vasoplegia. So here's 2 quick articles that prove that. In 2017, Tesouris and his colleagues, they retrospectively analyzed almost 2,000, 1992 adult cardiopulmonary bypass patients, and 405, or 20.3%, developed vasoplegia, according to that definition I gave a minute ago, by the way. Also, back in 2009, Dr. Levin and his associates, they looked at 2,823 of their adult bypass patients, and they also found 565, or 20.1%, developed vasoplegia. So this is the accepted incidence of vasoplegia post-bypass. Now, here becomes we're known unknowns, things we do know, things we don't know. And this kind of reminds me, Joe and Tammy, of the lectures that we've given on the causes of AKI, right?
Yeah.
There's so many risk factors that have been implemented or incriminated on causing AKI. And this is still the case now with vasoplegia. And here's a number of them. It seems that if you have one or more of these, your incidence of vasoplegia goes up. Age of 65 greater than 65, male gender, a recent MI, low ejection fraction, people with poor cardiac output, valve operations seem to carry a higher incidence, people with diabetes, heart transplants, or people with existing VADs definitely carry a higher rate of vasoplegia. Anybody that has any amount of renal failure, anybody that's on diuretics or dialysis, or even just mild diuretics have a higher incidence of vasoplegia. People that are on calcium channel blockers, people that are on amiodarone, people that have received blood transfusions, and you could probably rope in some others here and there and things that we still are trying to figure out. So what does this slide tell me? You guys are probably thinking the same thing. This tells me we don't really know what's causing this. Is it 1, 2, a combination of all of them, right? Same thing I think we fall into a lot of times with all the different risk factors that people have incriminated in with acute kidney injury. So now what's really interesting is if you read enough articles, you'll find, see, Joe and Tammy, ACE inhibitors emerged very heavily in the late 90s. And this is also coincidental with when vasoplegia seemed to emerge, because we didn't have this back in the 60s, 70s, and 80s. We didn't have this people with vasoplegia post-bypass. It emerged somewhere in the late 90s. Well, people said, oh, wait a second, well, what's changed? Well, that's when ACE inhibitors really took off. And a lot of studies incriminated ACE inhibitors as being a big factor, causative factor in vasoplegia. Beta blockers, by the way, have also been incriminated in vasoplegia. Well, fast forward to 20 or 23 or 4 years of research, not only have an equal number of studies incriminated both these things, there's been an equal number of studies that have shown that patients on ACE inhibitors and or beta blockers actually were protective against developing vasoplegia. So that's why these two are controversial risk factors. We have an equal number of studies incriminating them as well as showing that they are actually a preventive measure for vasoplegia. So what is the pathophysiology? It's complicated, and that's why I had that quote up there about Donald Rumsfeld earlier. But here's what we're going to do, and we're going to simplify it here in the end. But one of the primary pathologies is the SARS response, the systemic inflammatory response that we all talk about, and the subsequent release of all the various inflammatory mediators that goes along with it. What are those? The big ones. Oxygen-free radicals. What do oxygen-free radicals do? They damage your RNA, they damage your DNA, they damage lipids, they damage proteins, and they cause cell damage and cell death, particularly on the endothelial layer. Then there's something called prostanoids. These are accentuators or mediators of inflammation. Bradykinins are released, and these also promote inflammation, but these also release something called nitric oxide, which we're going to talk about at length here in a second. Then there's the release of cytokines. That's your TNFA, tissue necrosis factor A, interleukins 1 and 6. All of these upregulate inflammation, and they themselves cause tissue injury and tissue death. So all this is going on with our SARS response. But here's the biggest thing, that this SARS response results in the activation of something called nitric oxide synthetase. Nitric oxide synthetase produces nitric oxide, but it increases the level of nitric oxide in our system 1,000-fold. Further pathophysiology, though, is that we now have what develops because of all the things I just listed, endothelial dysfunction, which is related to and correlated to longer pump times, anesthesia meds and drugs, and people that are on mechanical circulatory devices like VADs. So what's happening here is you have exposure of blood to foreign surfaces, which activates multiple enzyme pathways and stimulates the inflammatory mediators that I just discussed and neurohormonal factors. The result is endothelial and vascular dysfunction, resulting in vasodilatation that is resistant to vasopressors. So now, there's vasopressin. Vasopressin is something that counters the effect of nitric oxide. Remember, we had just said there's over 1,000-fold increase in the nitric oxide that's being produced now on the endothelial layer, causing vascular vasodilatation. Well, the vasopressin counteracts that, and the vasopressin, by doing that, it helps us maintain our vascular tone, our vascular integrity. Well, there's significant evidence that vasoplegia is due to a deficiency in our vasopressin. Well, how did that happen? Well, you see, when you have a drop in blood pressure and your blood pressure is low, which is what's happening with this massive vasodilatation, your baroreceptors become hyperactive and like in states of shock, and this stimulates massive release of vasopressin. And after a short period of time, this vasopressin becomes depleted. It runs out. And that happens in a very short period of time in vasoplegia. Once the vasopressin runs out, now you have nothing to counteract this massive amount of nitric oxide that's being released. So this is a huge element as well to vasoplegia, is the depletion of our vasopressin levels. Now, this slide is meant to just give you how much we know and don't know about what's going on, but because the vasoplegia is multifactorial. I'm not going to go through all these. I just talked about the first 3 or 4 there. And in these things in red, you could look at any one of these. If you want to do it on your own, you could pick out prostaglandins or thromboxane there at the bottom. Any of these ones you want to pick out, acidosis, hypoxia, and it will result in one of these 6 red highlights that I have here. One of these things are all doing one or more of these things. They're causing nitric oxide production, they're causing endothelial dysfunction, they're causing cell damage and death. One or more of them is causing inflammation. Some of these are leading to vascular paralysis and a fixed vasodilatation. Some of them are disrupting our calcium and channel and potassium exchanges, which results in cellular hyperpolarization due to the calcium channel disruption. So one or more of these are the effects they're having, which, as you can see, the end result is a pretty firm and stubborn vasodilatation. So to simplify this, and here's a nugget for you, take-home slide, pathophysiology, the focal points, if you want to understand the pathophysiology of vasoplegia, you have your Sears response, which is releasing your oxygen radicals, prostanoids, cytokines, and nitrous oxide synthetase, which then produces a 1,000-fold increase in nitric oxide, which is a powerful vasodilator. They then have your drop in blood pressure causing all your vasopressin to be released, and eventually you have a depletion of your vasopressin. Now you don't have anything to eliminate and counteract your nitric oxide. Then you have endothelial dysfunction, which is further aggravated by your pump run and anesthesia meds. Here's another golden nugget slide to take home. How are we going to treat this vasoplegia? If you want to talk intelligently about it, oh, my patient has vasoplegia. Well, what should we do? The first thing you always do is you give the patient volume. The patient's massively vasodilated. They need to have a significant volume administration and norepinephrine. Volume and norepinephrine are the first 1-2 punch that all vasoplegia patients should immediately receive. If that doesn't get you out of the woods, and because some patients have mild vasoplegia, there's moderate and there's severe. So if you have mild, volume and norepinephrine are going to get you to where you need to be and get your blood pressure up. If that doesn't work, you need to go straight into your catecholamines. This is going to stimulate your sympathetic nervous system, your fight or flight, and that's dopamine, epinephrine, and phenylephrine. So now, also a nugget, a golden nugget slide is, what if those don't work? And quite often, by the way, those don't work in more moderate and severe vasoplegia. Your second-line agents are the non-catecholamines. Now, these have been shown to be remarkably beneficial because they moderate that nitric oxide and they moderate the SEERS response. And the big two heavy hitters here that people go to a lot are vasopressin and methylene blue. And if those don't work, and the research, all the research going into this, you now have what's called rescue agents, because sometimes those don't even work. These are your third-line treatments, and there's more non-catecholamines. You can have Giapreza, which is angiotensin II, a powerful vasoconstrictor on its own that works on a non-catecholamine receptors, vitamin B12, vitamin C, and corticosteroids. And we're going to talk just a teeny bit about what all of those do. But that's your treatment. So now what's the prognosis for vasoplegia? Why are we talking about that? Well, it's definitely associated with an increased morbidity, and that's the reason for that is because of your end organ failure. Remember, you're going to have hypoperfusion and increased lactates. It's a poor prognosis, particularly when vasoplegia is norepinephrine resistant. There's something going on here. Remember I said your first line treatments are volume and norepinephrine, but when you have a patient who's norepinephrine resistant and the norepinephrine is not working, you now have one level higher of critical seriousness of vasoplegia going on, and there's a much more poor prognosis when your patient will not respond to norepinephrine. So then you have what's called a catecholamine resistant vasoplegia, and if this lasts for more than 36 to 48 hours, it carries a mortality rate as high as 25%, depending on what studies you use. So you have now high-dose vasopressor therapy. This often leads to peripheral and mesenteric ischemia, as all you guys have seen with your, what do they call rocket fuel in the ECMO world? Mm-hmm. And all of this vasoplegia leads to prolonged ICU and hospital stays, more increased rates of renal failure, and frequent readmissions. And if you read the studies, you'll find that whatever your ICU and hospital stays are for your normal patients, it nearly doubles when you have vasoplegia involved. So here's a conclusion slide. This is also a golden nugget take-home slide. And I just have to read this. So this is if you want to know everything you can fit on a little, picture on your phone or a little 3x5 card in your pocket. Vasoplegia is primarily an inflammatory response. The subsequent release of various mediators results in endothelial cell damage. That's very important. Massive production of nitric oxide and potassium hyperpolarization of vascular muscle cells. This all causes vascular paralysis and profound vasodilatation, which is then vasopressor resistant. This decrease in blood pressure stimulates a massive vasopressin release, which soon becomes depleted, further aggravating the situation. First-line treatments should be volume and norepinephrine, followed by additional catecholamines as needed. Rescue efforts might include methylene blue, angiotensin II, and vitamin B12. So now, that is our nugget. Now we are going to go into the surprise gem of the week, what I mentioned to you.
Can I raise my hand, John?
Yeah, you have to stop the slides because this is going to flow.
Stop the slides.
Just stop the slide, Dave. Okay,
Yeah.
that's good. Go ahead, Dave. Go ahead.
Do we want to talk about that, or was that?
This is going to be a 1-minute segment, and then we'll have discussion.
Okay.
Okay.
So sorry.
So we're going to do the gem of the week. It's just a 1 or 2 minute segment. And what is the gem of the week? It's going to be another little nugget that's of interest to perfusionists and clinicians. It could be anything from interview tips and tricks, a perfusion trivia or medical trivia, a little nugget that we could put out there. It could be a career opportunity that we might feature one week, a real nice job offer. Could be something happening in perfusion news, like a recall. Could be some perfusionist that we're honoring, or something during perfusion week that is of interest to perfusionists. It could be a famous quote. I might pick a famous quote one week, and we might demonstrate that on this segment. or it might actually just be an interesting perfusion conference, like when we honored Terry Crane for over 50 years of perfusion excellence, the Texas Heart Institute recently. But this episode's Gem of the Week is going to be a career opportunity. Okay, every week it's going to be different, so you have to tune in to see what it's going to be. And this career opportunity is an excellent perfusion job offered by Houston Electrical Technologies. Yours truly over there is this is how you would reach them through phone number or email right there at the bottom of the screen. Okay, they're a full-service perfusion organization, auto transfusion and ECMO services. And go ahead to the next slide. So then, what is the job that's being offered? It's an adult perfusionist, permanent, full-time position. So it's not a pediatric position. But the location of the job is in fabulous Houston, Texas. I know that because I've spent some years there myself. So here's some interesting nuggets about Houston, why people might want to go there, Joe and Tammy. It's the 4th most populated city in the U.S. with 2.3 million people. And only New York City has more Fortune 500 headquarters than Houston. Houston is number 2 for Fortune 500 headquarters locating in Houston. It's a world-renowned state-of-the-art medicine city with over 85 hospitals and 30 heart hospitals doing heart surgery. There's a world-renowned museum district with 19 incredible museums that, by the way, attract over 7 million tourists a year that just go to that museum district. And Joe and Tammy, I don't know if you guys know this, but you do live in Houston. There's over 10,000 restaurants representing over 70 different cultural foods.
That's why I have to work out so much.
So why would you want to? Why would you want to go to work for this job? What is the reasons why you would, take this job? It's adult only. There's CABG and valves and aortic procedures and some ECMO. You have first-rate surgeons there in your accounts there, Joe, and excellent cardiac teams. I know you've talked highly about them many times before. Experienced and new grads are welcome to apply for the position. It has very competitive salary, excellent benefit package. You can contact Joe to find out more about that. But if you go to Houston, you're going to get world-class perfusion experience because you're going to be in the midst of a world-renowned medical center. There's an excellent work-life balance. I think you've had perf webs about that, Joe, talking about that there. And there's opportunity for advancement. So I think that is our gem of the week. And if you guys have any questions, comments, or suggestions for future topic for an upcoming show, email me at this web address, john.ingram@perfweb.us. And now I think we can go on to our panel discussion. Next slide. Yep. Thank you, guys.
Thank
Very
you, John.
nice.
That was very nice. Thank you,
Great.
John. That was very kind of you to let us be your first gem of the week.
That was a surprise.
We are hiring, so and we do. The only thing is, I would say that the slide was great. Most of the information I think was correct, but work-life balance right now doesn't exist. So I have to be, I think, a little bit transparent on that, but it will get better.
I thought I was going to hear about a job for me.
Oh, okay, yeah. Well, the other thing is, the other mistake you made is don't call me, call Tammy. She's the one you have to call to convince that we need to hire you, okay?
The word you've used a few times in our discussion so far is things are going to go on in perpetuity. So this presentation will go on in perpetuity, and hopefully a day will come where the work-life balance returns, right?
Correct.
We certainly hope so. Well, I'd like to do, can I do a part 2 to your gem of the week?
Sure, absolutely.
So
That's what we're here for.
I feel like I need to.
Okay.
So if you all go to the PerfWeb schedule, the PerfWeb Spring Conference is currently up and already approved for credits, although it doesn't say it on the website for some reason. I don't know why, but maybe it will one day. But it's going to be an excellent conference. It's Wednesday, April 14th. Until Saturday, April 17th. I think it's going to be about 25 or 26 credits, I believe. 26.1. Yep, it just says XX. It's going to be the first ever. And John, are you coming from the new studio?
And I forgot to introduce everybody. This is the new PerfWeb, Florida, PerfWeb, perfusioneducation.com. PerfWeb Studio. We are coming live. This is an actual studio with actual lighting, cameras, microphones. It's not coming from my living room or my office in my house or anything like that. And we'll be coming live to you every almost every 2 weeks. We're going to be doing these episodes,
Wow.
and hopefully people like the new look.
We do. I wanted to compliment you on that. It looks fantastic.
And the sound is great.
It
the
is.
lighting
You
is
sound.
great.
It sounds like butter, John. You sound fantastic. There's
We
This is
invested
really
in,
nice.
high-end microphones, a better camera. We're not just going off my laptop at home that can give all types of psychedelic colors in the background if the lighting's not right.
Yeah.
So
Well, I'm really.
we've got a
I'm
soundproof studio here where you don't hear any outside noise. We're isolated. So and we're in a fabulous part of Orlando, a very nice part of the city as well, right on the lake.
Great.
Well, I'm very humbled by your efforts to do this, and it certainly is appreciated by myself, Tammy, and I know that the audience at large. So thank you so very much for that. But getting back to the PerfWeb Spring Conference, which will be PerfWeb 57 for those who know, it will be, and John, you're one obviously, but it's going to be the first ever multi-studio, multi-day, interdisciplinary virtual educational event. And so that's my gem. The second, you get 2 gems this time, okay? So I suggest you get on there, get registered.
Buy one, get one free.
And,
We bought one and we got one free.
Buy one, exactly. You buy one and get one free.
Of the gems.
Of the gems, yeah, that's right. Well, but our programs are all free, so you just get 2 for free. So you get, this is called Land Yap in Louisiana, right?
Right.
And so, but anyway, go on the website, check it out. We've got an incredible faculty. We have incredible topics. You know, we're trying to do this in the same vein as the New Orleans conference. We're going to have some surprises that aren't even on the website yet. But it's going to be, you know, I can't wait to get back to regular conferences that are in person. But in the meantime, we're going to try to make the online conference experience the best it can be. Okay, so that's mine.
Real quick, can I expand on that?
Yes.
It's going to be multi-studio, and we don't mean Zoom call.
No, we do not mean Zoom call.
We mean multi-studio like John's.
Yes.
And like ours.
And ours. Yes, we're going to have we're going to do this. If we're going to provide content, we want it to be commensurate with what our job positions actually are. We're professionals, and what you're producing needs to be professional. It needs to, it's, you know, I say this all the time, right? You've heard me say it. It's not enough to be good, you got to look good or no good. And that's just, you know, one of my sayings that I've had for most of my life. And I think that's very important. When you're producing something that is going out on the web, it's very easy to do Zoom calls. It's very easy to do it that way. But it's not, that's not Fox News or CNN or whatever news station you want to watch, whatever your flavor is, I really don't care. But every single one of them, they don't do Zoom calls. That's not how they do it. They have studios, and they put it, and they make sure that the lighting is good, and the sound is good, and the graphics are good, and the you know, you can actually listen and feel like you're a part of something, and that's what our goal is. So, John, let's get on to the discussion, because I think you gave an excellent overview of vasoplegia. Some things that I knew and some things that I didn't know.
There you go. You just,
Yes,
I just wanted to point out real quick, because it wasn't on the slides, and I wanted to tell people what these treatments do real briefly. So if you give somebody, you know what volume and norepinephrine are going to do, but what if that doesn't work and you have to give somebody vasopressin? Vasopressin, it increases the intracellular calcium. That's what I want you to know, which this drives vessel contraction. Methylene blue is a nitric oxide production inhibitor. In other words, methylene blue, the reason why you hear about this is that all this nitric oxide is being produced by nitric oxide synthetase. Well, methylene blue interrupts and interferes with the further production of this nitric oxide that's run amok. If you give somebody vitamin B12, this is a nitric oxide scavenger. So this is why vitamin B12 has worked for some people, and some people have written papers on it, is that you give somebody vitamin B12 and it's going to scavenge up a lot of this excess nitric oxide that's causing this, you know, this resistant vasodilatation. if you give somebody the angiotensin 2, now this is its own, we have our own angiotensin receptors in our blood vessels. So this is separate from catecholamine receptors. You give somebody angiotensin 2, it's a powerful vasoconstrictor, but in addition to that, it causes antidiuretic hormone secretion and increased water reabsorption. So these things, in addition to the vasoconstriction, are going to help increase the blood pressure, which is really the core of the problem here. If you give somebody corticosteroids, that was one of the ones on the list about a third or last line treatment. This is going to reduce your inflammatory response. The same thing with vitamin C. It's a potent antioxidant. So remember, all this inflammatory response that was happening from the sears, these things help blunt some of the inflammatory responses. So there's a multitude of things going on here, but most of them address either the inflammatory response, which is causing all your endothelial injury and your aggravation of the nitrous oxide production, and the other things you give either blunt the nitric oxide production or scavenge it. So those are kind of where the treatments have been aimed so far.
Well, I'm surprised, John, and I think, I've been confronted with this. I've seen this a few times. I don't know that I've seen it 20% of the time, but maybe there's a milder. I'm assuming that the severity is graded mild, moderate, or severe. The severe form of it I've seen several times, but I don't think it's anywhere near 20% that I can recall, certainly. But what I'm surprised about is that there's nothing, in the data that you were able to elucidate that talked about either some form of molecular adsorption therapy, like the cytosorb filter, and nothing in the data, as far as the evidence-based data for treatment, and nothing in there just about standard continuous veno-veno hemofiltration with high volume replacement. So, I think both of I have a very strong sense of underutilization of those therapeutic modalities. But what's your view on those as far as how to manage these patients?
So this topic is something you could literally spend an unlimited amount of time on. The understanding this topic it's endless right now. We don't understand really the meat and potatoes of the pathophysiology. We are on the outskirts of understanding what's really going on. We're on the outskirts of understanding what's causing this.
Mm-hmm.
This did not exist until about 23 to 25 years ago.
Mm-hmm.
We had millions upon millions of patients on cardiopulmonary bypass, and we did not have something called vasoplegia. People got into the ICU and they responded to your, catecholamines and so on, like you would expect. And it started showing up in the late 90s where they were unresponsive, certain percent. But so there's so much research going on to what's causing it, and as we begin to find other causes, we begin people researching other treatments, and there is a whole myriad of people out there and research ideas on treatments, and you could list the two that you listed were two excellent ones, and there's so many even more, and that's one reason I tried to accentuate at the beginning of the presentation that this was going to be to the point, short, concise, and powerful, as opposed to a 90-minute lecture where we dove into the weeds about 1,000 things and you come out with a headache at the end. But this is a topic that is worthy of, months of study and people researching it endlessly, and that's what's going on. And there's so much that we think we know, there's so much that we don't know, and we're finding out every day. I think all those are escalating. More that we know is more that we don't know. But you're right, the 20% includes a very mild version, a moderate version, and a severe version. And I do have studies. If people email me, I have studies that break it down. Again, how do you define that? How do you define mild, moderate, and severe? But there's studies that have taken and put together mild, moderate, and severe. And the severe is probably about 5%.
I think the other thing too that I wish was more well accepted in terms of being able to truly diagnose vasoplegic syndrome is that microvascular scanning
Yes.
camera, so that you can actually see the the high velocity flow pattern that you see with that, and a lot of what I guess would be the capillary bridging that takes place. You would actually be able to see that. And if you could visualize it, and I really think that scanner has so much potential utility at being able to confirm a diagnosis, because if you believe it's vasoplegic syndrome, but we are, I do believe, inferring an awful lot from it. Yeah, it meets this criteria, but when I looked at the criteria, that can be a lot of different things. It doesn't necessarily mean it's actually vasoplegic syndrome. And so you're treating something based on what you believe it is, and that could put you behind in terms of either treating it sooner if it ends up that your scanner actually confirms it and says, yeah, that's what it is, or that no, the scanner saying, no, that isn't what it is, this is being caused by something else. You could see a sluggish pattern, for example.
Yeah, the sluggish pattern, right?
I've seen that before too, where that would not coincide with this particular disease. Because I've seen those. You can actually find those images, those videos on the web, and you can see in these vasoplegia patients, the flow going through the microvascular system very rapidly. It's amazing at how fast it's running, and it's almost not a long transit time through the capillary system, through the capillary themselves, to have any exchange, and a lot of it's going around. Whereas I've seen other situations where you had similar hemodynamics, but your flow pattern was very slow and just very strange as it transitioned through the microvasculature. So I wish that technology was better understood and better, more widely utilized. It's kind of disappointing to me because I really think that it has great value.
Yeah.
Yeah. Let me point out a couple things that you kind of touched on, but reminded me. You're going to find studies, anybody who looks into this will find studies. Let's say, for example, methylene blue is kind of a hot topic. If somebody has vasoplegia, let's give them methylene blue.
We've largely
and
abandoned
people are like, well, it doesn't
Yeah.
work. Some
I don't
people
hear
are
it
like,
that
well,
much anymore.
that's hit or miss, doesn't work. Some people, oh, no, it works great. We don't know on, for example, vitamin B12. There's a physician in the University of Florida who's touting vitamin B12 as a savior to vasoplegia. Other people do it. They don't have good results. The reason is that, for example, with methylene blue, with vasopressin, with angiotensin, with vitamin B12, these are some of the big ones. We don't know on a lot of these studies, did they give it too late? Did they give it not in the right time and in the right dose? We don't know. These are all off-label uses. All of these things are off-label use for the treatment of vasoplegia. So you'll see a study that says we did methylene blue, it didn't work. You'll see a study that says we used it worked great. Well, they gave it earlier, and they may have given a different dose than the people who waited too long, right? It's like ECMO. If you wait too long, you're never going to be successful, right? And this is very, very true right now with these second-line treatments, everything beyond volume and catecholamines, vasopressin, angiotensin, methylene blue, vitamin B12, even steroids and vitamin C. We don't know when is the best time to give these, and we don't know how much we're supposed to be giving.
Well, yeah, I completely agree with you. And earlier, look, I mean, we all know earlier intervention actually does work. If you put patients on ECMO, within 48 hours of their intubation, and they had not been so delayed in intubation that they were in extremis by the time they got to that point. I mean, there's so many things, and our healthcare system is having such a hard time actually appropriately timing therapy.
Right.
And it depends on where you end up.
Yeah,
what hospital do you end up?
And is there a bed for you to go somewhere where there is treatment?
And how many times have we taken a consult for ECMO insertion who was failing ventilatory support, only to get them and have the ventilator tweaked in such a way that all of a sudden, well, this patient really doesn't need ECMO.
Right,
We've
we
had
get
that
into a
happen.
place that, we get it to one of our ECMO centers where we've got really experienced, very knowledgeable
Pulmonologist and intensivist.
yeah, and they work together, and we've been on ECMO watch like every single day.
Yes, absolutely.
We get called about a patient, a transfer coming in, and of course some of them happen, but many of them, I think, what was it, last Friday I got ECMO watch for 3 of them, and none of them
Materialized.
none of them, all the patients came, they were all transfers. But once they got there, they reevaluated, they proned them, they did some different things, and they were able to avoid it, at least for the time being.
Very good. Excellent. John, great looking studio, man. I appreciate it so very much.
Yeah, it's
Fantastic. You looked great tonight. Much in contrast
Yeah,
to the last time. The last time I told you looked like hell before the program went on, and because your shirt was so bad, you got up and walked out. Everybody was like, I guess John's gone. But then you came back with a new shirt, which was very nice.
Oh my gosh. And the program, I really like the new segment. So I think this is going to be fun.
It is going to be fun.
So Tammy, I got an idea, idea for your show if you want to have a new name. I just thought of it. What you can do is you get one of those spin wheels, right? Like a Wheel of Fortune spin wheel.
Yep.
And you have already, say, 5 or 6 topics already prepared to go. And what you can have is something that rhymes with Sparacino. You could have Tammy Sparacino's Journal Club Casino. And you don't know what the topic's going to be. You spin the wheel, whatever it lands on.
Why didn't we get him for marketing?
He's been, yeah.
That's great. I love it.
John had an interesting life as a younger man, and I think a lot of that is residual effect.
I love it.
Okay, because I can tell you right now, that's pretty creative.
I love
That's
it.
very creative,
Tammy
John.
Sparacino Journal Club Casino.
I mean, I might have to take you up on that. That's T-shirt quality.
I like that. And you're going to have to do 5 or 6 topics in advance in your spare time.
Or
And you got
something
so
like
much
that.
of that.
Or something like that.
I do.
That gives you the baseline idea. You can take it and run with it.
Yeah, thank you.
John, thank you. We're looking forward to the next one. When is the next one?
Yeah,
I think
February
it's
10th.
February 10th.
February 10th.
Second, yeah.
February 10th, yeah.
Yeah.
And that'll be our second for 2021.
Yeah, moving forward,
And-
we're going to have 2 a month.
2 a month, yes.
Yeah. We had a little
correct.
bit of
The
a
next one
break.
is the next one is February 10th, not
Yes.
22nd.
Yes, sir.
February 10th. Okay.
You
I
better
gotta
check
see
that schedule, John, because there's a knowledge nugget on there.
Yeah, you're probably
I guess I
expected to
better show
attend.
up.
And hopefully by then I'll be able to make an announcement about the other thing that we're working on. Hopefully by then, I
Yeah.
think so.
Okay.
So let's
Yeah,
hope
because
COVID.
Oh,
in the
that.
end of
I thought we were
2020
referring to my.
in the
No, that too.
I did leave the set,
We may even get one and put it in here. You could spin it.
but I did leave the set. Remember, I promised.
Yes, that's true.
That was for emergency calls. So.
That's right.
So,
Yeah.
Joe, you at the end of 2020, you promised me, you promised the audience some big surprises in the PerfWeb program in 2021. So I'm still waiting.
Knowledge nuggets.
Yeah, that was
it,
one
huh?
of them.
Tammy
Okay.
Sparacino Casino.
Yeah, right.
Journal Club Casino.
Multi-studio.
Multi-studio
Yeah,
spring
Conference.
spring
Yeah.
conference. Virtual
I
conference.
like that. I
Yeah.
like that.
I mean-
Multi-studio. So
I mean, I'll send everybody VR, things if they need them. Those what are those Oris? What are those things called? What's the one? Huh? Oculus. Yeah, and
Oculus.
we can all sort of be in the same room together in a virtual world. So we'll figure something out. But it's been we're certainly are getting there, John. And
Yeah.
thank you. And your contribution to this cannot be understated and nor overappreciated. So thank you very much.
well, we have fun doing it, don't we? I think we do.
Yeah,
I think we do. Okay, everybody. February 10th. Which camera am I on? This one?
We're over here.
There's 3 red lights on.
But we're here.
I'm here. I don't know where I'm supposed
We're
to be.
here.
February 10th. I will see you all at, I think it's a morning program for
Yeah.
our European partners and those folks. 'cause
And we
do it
moved
in
to
the morning.
Wednesdays now.
And we moved to Wednesdays. That's right. So we're doing Wednesdays and Thursdays
Yes.
to accommodate some, everybody's schedules.
Yeah, absolutely.
Okay, beautiful. I'll talk to y'all later. Be safe. We'll see you February 10th. You have any questions? John Ingram at john.ingram at perfweb.us. You can always hit contact or info. That'll come to info at perfweb.us. That'll come to Tammy and I. And we'll look forward to seeing you soon. Thank you for your support. Don't forget to YouTube, subscribe, all that stuff. Go visit our sponsors. We need more sponsorship. And HET on our Gem of the Week is hiring. So if you're an experienced perfusionist would like to move here, or you're a new perfusionist, a new graduate perfusionist. In fact, we just hired 2. And we also have a seasoned perfusionist. Hopefully we're going to be picking up very soon as well. So our group is growing, our business is growing, but that's a separate component. While we're here, I like to focus more on the educational component of it. So stay safe, stay COVID-free, get your vaccine as it becomes available to you, and I hope everyone has a great 2021. Thank you all.
Good night.
Night, guys.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low-pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.